Bad breath on you, so I always had a bottle of scope in the employee restroom. Actually, I had it in my drawer and then I used it. And I would freshen my breath probably about every 2 hours. Since we all can't drink out of the same bottle of scope, you can bring your own mints with you. I'll have mints here. And you'll freshen your breath. You're going to walk in and introduce yourself to the patient and explain what you're doing. Each one of you will wash your hands before you actually come in and do this. However, I will have hand sanitizer. In a regular environment, you would have a sink in the exam room and you would wash your hands in front of the patient. So you come in, walk in. I'm Rachel, my name's Lenny Corson. I'm the physician assistant here today, and I'm going to be doing a pre-employment exam, and part of that is a cranial nerve exam. I will explain everything that I'll be doing to you, and we'll go from there. Okay? And at that point in time, you take your little hand soap. You notice this has tiger stripes on it too. Okay? All right. You will be responsible for identifying every one of these. Now I'm going to tell you, you need to learn this really well because it's going to be heavy on the next test. Okay? Olfactory nerve is sensory, and you're going to ask the patient, have you had any problems with smell or breathing? Totally different. Smell is different than breathing, right? Can you get air past the nostrils? You're going to check for, I shouldn't have 4 of those things. All right, I'd like for you to take your index finger and press against your nostril and sniff. Any problem with getting air through there? All right. On the other side, please. Sniff. Okay. All right, very good. Well, I guess I didn't have the bar stove. All right. At this point in time, this is more of an exam rather than neurological, but it's a good time to do it. You're going to take the otoscope, and all you're going to do is say, I'm going to check inside the nasal area there for any polyps or deviated septum, which could interfere with the air going in and out of the nose. At this point in time, this is my bar of soap because it's all down in the lab, is I'm going to take the bar of soap and I am going to have you close your eyes. And I want you to press against one nostril, and I want you to smell, and then she would tell me what it is. Now, in a regular clinical environment, you'd have a variety of things that they would smell. Obviously, they're going to know it's soap, but that's okay. You say it's soap, and then you close the other nostril and sniff. And you ask them to smell, and they'll say it's soap. Okay? Okay, the next nerve is the optic nerve. It's cranial nerve number 2. It's sensory. Ask the patient if they have any problems with it, haven't had any problems with their vision, and have you?
No.
Okay. When's the last time you saw an optometrist or an ophthalmologist?
Within the last year.
Within the last day?
Year.
Okay. And at this point in time, you would have her, and I don't have the eye chart, but we'll have the eye chart up here. And since we don't have an eye chart, I'm going to have you cover your right eye. Okay? And can you read those letters for me up here? Talk about going cheap.
Fire. F-I-R-E.
F-I-R-E. What color do you see?
White and red. The letters are white.
What's this? What color is that?
Red.
Red. What color is this over here?
Green.
Green. All right, let's switch to the other eye now. Can you read these letters?
F-I-R-E.
Okay. What you would do on the Snellen eye chart is you'd have them choose the smallest line they can read. You let them choose, okay? And I'll have one hanging up here. All right. Then I'm going to check for the peripheral vision. And you do this very slowly. Let me turn you just at a oblique angle here a little bit. There you go. Okay. I want you to focus in on my nose or my finger, and you let me know when you see my finger without moving your eyeball. Tell me when you see my finger. Say now. Okay? Okay? Checking for peripheral vision. Now at this point in time, and you won't change the heads because of time constraints next week, but you put this on, you say I'm going to use the ophthalmoscope, and I'm going to do a fundoscopic exam. I'm going to look at the internal part of the eye, and that's all you have to do. Okay? This is the way you normally do it. You just switch eyes. Okay? You haven't been trained on that yet, but that's, you just tell me that you're doing that. Okay, and so then you're going to move on to the ocular motor nerve, which is motor, and you're going to observe for nystagmus. Now, I'll show you these real quick for the videos. Nystagmus is the eyes are just moving rapidly back and forth. Strabismus is you have a wandering eye, either they wander out or wander in. Ptosis is a droopy eyelid. And anisocoria is unequal pupils. So what you're going to do is you're going to take the little pen light and you're going to flash it in the eye once to see if the pupils constrict. And the second time in the same eye, but I'm looking at this eye over here to see if it constricts. And you look and your pupils are equal to, pupils equal and relax to light and accommodation. At this point in time, you're going to explain that the parasympathetic controls the pupillary constriction, pupils constricting, through the circular intrinsic eye muscles. You have two types of eye muscles. You have the intrinsic eye muscles that are internal with the pupil, and you have the external eye muscles which move the eyeball around. You'll indicate that the sympathetic system controls the pupillary dilation, and with the radial intrinsic eye muscle. You will also indicate, you have to indicate which of the external eye muscles are involved with each nerve. At this point in time, I'm going to indicate that the superior medial and inferior rectus and inferior oblique extrinsic eye muscles will be involved with the ocular motor movement, or the ocular motor nerve. The trochlear nerve is motor. It's going to involve the superior oblique. And you're going to skip 5, go down to 6, and it says the abducens nerve is going to control the lateral rectus. These are all the extrinsic eye muscles. They're all motor nerves. How do you check for this? You're going to look at my finger, and I want you to follow my finger. We're going to go up, back to the middle, down, to the left, or to the right, right. Okay. We're going to do the oblique, which is the X. So you do a plus and X, come back to the middle. Follow it all the way to your nose. That's convergence, okay? So that takes care of, once you've identified the extrinsic eye muscles, that takes care of 3, 4, and 6. The trigeminal nerve is both. You're going to test for gross sensation with a pen, and that is sensory, and you're going to check for the motor movement, which is the masseter muscle. So I'm going to start out, I want you to clench your teeth for me. And I feel that. She's popping out her masseter muscles. I check for the motor movement. And now I'm going to check for the sensory. And the sensory, so we don't draw blood, we're keeping this closed. If I poke like this on your face, that's sharp. If I do this, it is dull. Okay, close your eyes for me, please. Put your hand down. Okay. Sharp or dull? Okay. Okay, very good. All right, check for sensory and motor on that. And now it is time to move from 5. We skipped 6 because we've already done it. Going to 7. Through this exam, you'll have to indicate or ask the question, any problems with taste? And twice. One is for the anterior part of the tongue, one's for the posterior part of the tongue. Facial nerve is both. Do you have any problems with taste? Okay. And then I'm going to have you smile, puff out your cheeks. Okay. And I want you to close your eyes really tight and don't let me open it. You're going to take your index finger and thumb and try to open them. She's got good tone there. She's holding back good. That takes care of the facial nerve. Then we have the vestibular cochlear nerve, which is sensory. You have to ask the patient if they have any problems with hearing, any tinnitus, which is ringing in the ears, any vertigo, which is dizziness. Okay. Then I'm going to take, again, you just pick this up and you say I'm going to check inside the ears for any cerumen impactions, any bulging, scarring, or perforations of the membrane. And you look at one ear and then you look at the other ear, and that will take care of that. That will be suffice. Then, in certain environments, you have an audiogram that you can use, audiometer, I should say. Since we don't have here, close your eyes, please, and tell me where you hear the sound. Okay, that'll allow for a little quick check on the hearing. Then we're going to do the Weber and the Rhine test. The Weber test is a bone conduction test. You have a tuning fork. The key is to hold it at the base. If you hold it like this, you won't get a vibration. So you go, hit it, and you're going to ask the patient, do you feel it in the middle, right, or left?
The right.
Feel it on the right.
I'm doing it now. Yeah, it's in the middle.
All right. Should be in the middle. If there's a problem, it will lateralize to the right or the left, and that has happened in this class, okay? That's the Weber test. Now we're going to do the Rhine test. And the way it works is you hit this and you put this on the back of the mastoid process, and you let the patient tell you when they no longer feel it. Okay. Tell me when you no longer can hear it. Right? The air conduction is usually longer than the bone conduction. Okay? I have a video, if I can find a little girl on there, she'll show you she has a problem with her right ear, and she can feel the bone vibration, but she can't get any air conduction at all. Okay? If there is an abnormality, it will lateralize to that affected side. At this point in time, we're going to check for balance on the ears. I'll have you stand up. And I want you to put your arms out with your fingers out. Close your eyes, touch your nose with your right hand. Okay? And then with your left hand. All right, fine. You put your arms down now. And with your eyes open, I want you to lift your leg. Now, what I do with the patient is I always stand close, but I don't touch them. In case they start to fall, I can grab them. Okay, lift your right leg. Knee up. Okay, good. Down. Other one. Okay, down. All right. So now check for not only hearing, but the balance. Okay, go ahead, have a seat. Number 9 is the glossopharyngeal nerve. It's both. Again, this is where you ask the patient about taste again. Do you have any problem with taste? Okay, at this point in time, you're going to take your fingers and you're going to put them up under the throat, and you're going to ask them to swallow. You must have, you can't say swallow when your hands are out here. You have to be right up there and feel the swallowing. Okay, the next one is the vagus nerve. It is both. You point out the fact that the sensory is difficult to check because it's internal, controls the heart and all that kind of stuff. But I've noticed that she's been speaking clearly, so I know that portion is working well. And then I'm going to have her say ah, and I'm going to look at the uvula. Stick your tongue out. Come on, there you go. Now I got to look at the uvula. The uvula flips up. Okay, at this point in time, you move on to the spinal accessory nerve, which is motor. Evaluates the strength and movement of the trapezius muscle and also the sternocleidoid mastoid muscle. Okay, I want you to turn your head to the right against resistance. Come on, harder. Okay, the other way. Okay, very good. I'm going to come behind you. I want you to shrug your shoulders up high. There you go. All right. And then finally, you've been waiting all night to do this to me for the hypoglossal nerve. It's the muscle of the tongue. Stick your tongue out at me. All right, there you go. So go to the right with your tongue. So you know, left, up, and down. Okay? Now that takes care of that. Now, if you miss something because you're still in the exam room, you can say, I need to go back to cranial nerve number 5 because I forgot to do this. That's perfectly fine. You're still in the exam room, you can do it. Once you say this concludes the cranial nerve exam, then it's all done. Okay? Typically it takes about 15 minutes. So with everybody here, it's probably going to take us the full 5 hours for the night. Okay? All right, thank you very much. Appreciate it. Okay. Now,